Alright, hi guys. Today I'm going to be talking about RAAS cardiac drugs. I was recently chatting with one of my underclassmen that I TA'd for, and they were mentioning that one of the classes that they were nervous for was the second part of their pharm class. So I decided to make this guide or this little refresher for y'all. Um, I didn't have the same professor as they did, so I can't exactly say for sure this will be on that professor's exams. But even if it's not, he should cover it in one way or another. And if even if he doesn't do that, it will be on your NCLEX. Sorry, I wiped my computer screen there. It will be on your NCLEX. So like these drugs are probably amongst the, or they are among the top 50 testable drugs. If you guys look it up, you'll see these drugs on there. Okay. So to first understand this topic, we're going to go over RAAS, okay, the renin-angiotensin-aldosterone system, okay. Um, so for me, I like to understand what kicks off this system, what triggers it, and what are the goals, right? So what triggers it is when the body detects low blood pressure, like due to low blood volume or whatever, like a hemorrhage, or low sodium. This will trigger it, right? And the goal is obviously just the reverse of it. You want to raise blood pressure and raise sodium levels, okay? We're going to ignore all the lines for now. So we're going to start off here. Renin, the R, it starts the cycle off. It's this enzyme. It has a role in causing this conversion here. So angiotensinogen is a protein in the liver, and renin causes it to turn into angiotensin 1, okay? Now, angiotensin 1 travels through the bloodstream, and where it goes to the lungs, and angiotensin converting enzyme will convert it into angiotensin 2. Okay, now angiotensin 2 is the big player in this system because it does four big things: vasoconstriction, aldosterone secretion, releasing ADH, which is antidiuretic hormone, and thirst stimulation. Now, the big ones I would say are like aldosterone secretion and release ADH. These are like 1A, 1B, and then this could even be like 1C or like 2A in terms of priority, and then this is like probably the least important one to remember, but these are the ones I would mainly focus on. So we're going to take a look at what happens if angiotensin 2 gets that aldosterone secretion going. Okay, aldosterone is in charge of promoting the reabsorption of sodium back into the body and excreting potassium into the urine. Okay, so when you excrete potassium, you're going to be losing it. Sorry, my cat wanted to chime in there. Sodium is getting reabsorbed, right? And the common saying we say in nursing school is water follows salt, right? So when salt goes back into the body, water is also coming back. So which is why you see sodium and water in, potassium out. And because the sodium and water are coming in, it raises the BP, raises sodium levels. That's how I always remember like what it does, right? Like what electrolyte is coming in and out, right? I always think back to the goal. So sometimes I get confused, like is potassium the one leaving or is sodium the one leaving, right? And I just think back, what is the point of RAAS? RAAS is to try to raise BP and raise sodium levels, okay? Um, the next one is to talk about is releasing ADH. So it is also known as a tap water hormone because it doesn't involve salt, okay? So there's no salt in here, it's just water. It directly increases water reabsorption, and on a side note, it also causes vasoconstriction, okay? Now, the drugs we're going to talk about are ACE inhibitors, which work at this step, and then angiotensin 2 receptor blockers work at this step, the angiotensin 2 part, and spironolactone, this diuretic, it works on the aldosterone secretion part. It blocks the aldosterone here, okay? So understanding the system and where all of these drugs affect the system will help you understand the side effects and big things to look out for, okay? So angiotensin converting enzyme inhibitors, also known as ACE inhibitors, the big thing to know for their naming wise is that they all end in pril, right? So these are your pril drugs like lisinopril, citalopram, enalapril, all these prils, right? These are the need to knows, basically. Therapeutic wise, we use it for hypertension, right? High blood pressure, heart failure. And this one is just more of a fun fact, so maybe not so need to know, but in case you guys get tested on this detail, on a very basic level, it's given so that there's no compensating hypertrophy of the heart muscle after an MI. Because of the increased oxygen demands and stuff. That's a little like complex and too much detail, so I don't really want to get too much into it. So the big ones are just mainly like hypertension, heart failure, and maybe you can throw an MI here. Adverse effects, the big one, there's several, but one of the big ones, in my opinion, are the first dose hypotension and orthostatic hypotension, right? That change in systolic or diastolic blood pressure by 20 or 10 milligram or millimeters per mercury. This is something you need to watch out for, right? Because you don't want to bottom out your patient. Angioedema, the swelling, the facial swelling, and the allergic reaction, basically. This is life-threatening. You want to watch out for this. Hyperkalemia, which is increased potassium, is a direct result of this system being shut down, right? Because you're giving the ACE inhibitor, and the ACE inhibitor works here. So all this flowchart, this rest of it doesn't work, right? So there's no excretion of potassium. So basically, you're keeping the potassium in the body here, which is why you may end up with hyperkalemia, too much potassium, and that's bad because it can cause heart dysrhythmias, which can kill your patient. The big, really classic symptom that is really like testable is the cough, right? Like if your professor really wants to throw you a freebie, it's going to be like your patient is coughing, like, you know, what kind of like antihypertensive are we giving them? You should know it's ACE inhibitor, so don't miss this freebie. This is so free. The last one is fetal harm. I rarely see this ever being talked about. Maybe in like maternity, I would see it, but even then, it was like very rare. Okay, so if like you can only remember three, I would remember the low BP, the cough, and the hyperkalemia. Angioedema, maybe, but I don't really get tested on that much. Some notable things is that it doesn't have an effect on heart rate, and you always want to check the blood pressure and potassium before giving it, okay? Because of the dangers of the low blood pressure and the hyperkalemia. You don't want to bottom them out, and you don't want to send your patient into a dysrhythmia, okay? If you guys can remember that, you'll kind of understand why it interacts with these drugs, right? Diuretics, getting rid of all the excess water in the system, it's going to lower your blood volume, so you're going to bottom them out. And other antihypertensives, right? You're going to exacerbate the blood pressure lowering effect given with ACE inhibitors, okay? So just be really careful when you see like these drugs given together. Make sure you're not like bottoming out their blood pressure. Always check the blood pressure, or even ask a doctor if you're concerned, right? Now, drugs that increase potassium, we just said, because adverse effect 3, hyperkalemia, because you're shutting off the excretion of potassium, you want to make sure that their potassium levels are okay. So if you're giving drugs that increase potassium with ACE inhibitors, you need to be really cautious about that heart rhythm, right? Lithium is a funny one. This one like is pretty testable. I remember seeing it on like NCLEX prep and psych related questions, because it's often the first line of treatment for a BPD, right? But basically, sodium and lithium, like the reason why it interacts with ACE is because sodium and lithium compete for reabsorption in the kidney. So if you're giving ACE inhibitors and it's blocking the sodium reuptake, right? If it's blocking this process, that's going to end up taking more lithium. Also, NSAIDs interact with ACE inhibitors because the nephrotoxicity, and this plays a huge function in the kidney, right? You're affecting the kidney here, so it's pretty nephrotoxic. Now, angiotensin II receptor blockers, also known as ARBs, literally the two biggest things you need to know are the name. So they end in sartans. These are your low sartans, valsartan, and basically this. What you need to know is that it's basically like the copy-paste version of ACE inhibitors, except there's lower risk of cough. You can even go as far to say like no cough even on the exam, but you know, never deal in absolutes, right? It's just like you might get a question like your patient's complaining of the cough and they're on ACE inhibitors, right? So what would you ask the doctor to prescribe, right? It will be ARBs, because They lower the risk of cough, and they also technically have a lower chance of angioedema, but the big one was usually the lack of cough, if anything. Also, therapeutic wise, I didn't put it on here, but they also have this added on effect of working pretty well with migraine headaches. But I don't know how relevant that will be to your classes if that's too much detail. But literally, it's the exact same thing as ACE inhibitors. Make sure you're checking that blood pressure and stuff, because we are worried about that, right? Spironolactone, which is the last drug we're going to be talking about today. The brand name is Aldactone, and the class is a diuretic, okay? And like most diuretics, when used in a cardiac case, it's usually for heart failure and hypertension to basically ease the workload of the heart. The big adverse effect is that it can cause hyperkalemia. Spironolactone is unique because it is a potassium-sparing diuretic, and if we go back to the chart, you can see why, right? Because this whole drug works here, which prevents potassium from being excreted, which is why you're going to have that increased potassium. So once again, be careful of the dysrhythmias, right? So it works by blocking aldosterone, and as a result, it binds to other steroid hormone receptors, which is why the other adverse effects I didn't include here are usually like steroid related. So like these are really common steroid side effects like the hysterism and deepening of the voice. Depending on the gender, like this can be an adverse effect, or you can even use it to treat it, but that's like a little bit too advanced. Okay, so basically just know that like hyperkalemia is the big thing you need to worry about because it is potassium sparing. That's like the big thing. So basically, to recap, ACE inhibitors, they end in pril, they cause cough, hyperkalemia, and the low blood pressure here. Don't forget the angioedema because that's also like slightly testable sometimes. They lower blood pressure, so always make sure you're checking BP and potassium before giving. ARBs, literally the same thing. They end in sartan and just less of a risk of cough. And spironolactone, potassium sparing, hyperkalemia. As the adverse effect, they're one of the only diuretics to do this. So that's pretty much all you need to know. If you guys have any other questions, you can leave them in the comments. If you guys, for my underclassmen specifically, if you have any topics that you guys have any questions on, I can try to make a video for you guys. My goal is to make a video every Sunday, and I usually try to upload it by 8:30 on Sundays. So let me know. I just started my first week of like real patient care coming up. So I'm going to be busy in my new grad program, but just let me know and I'll do my best to help you guys out because, you know, teaching is always just really fun for me. So yeah, good luck on studying. Hope you guys had a great week. Bye.